We'll move to the next presentation from Medicine 3, Micro to Macro by Dr. Akash Kumar.
Good morning, everyone. My topic is micro to macro. I'm presenting in behalf of Medicine 3. So, her history begins with she is a 51 years old lady from West Bengal. She presented with the chief complaints of swelling over her neck bilaterally for the past 16 years. She was apparently well before 16 years, that is by around Jan 2007. She accidentally noticed a small, non tender, palpable swelling below her mandible when she had upper respiratory tract symptoms. At that time, she consulted a doctor and she was assured at that time it could be a probable reactive lymph node. So later on, but she noticed the swelling had become bilateral and it was gradually increasing in size. By 2007, she again sought consult and biopsy was done in that time on 2007. FNAC it showed granulomatous inflammation and biopsy showed sinus histiocytosis. She was given some oral medication, no reports of that, for 10 days and then asked her to follow up. But the patient did not follow up and she opted for homeopathic medications. Swelling continued to increase in size and for the past 1 year, she started having breathing difficulty in lying down flat. It started compromising her airway gradually and because of which February 2023, she underwent tracheostomy. So at that time, biopsy taken, it showed lymphoplasmacytic infiltration, followed by which she came to CMC for further management. She had no other history of fever, no features of hypo or hyperthyroidism, no history of loss of weight, no history of hemoptysis or cough. Past history, she had no other comorbidities. Personal history, she has no other significant family history or personal history. So on examination wise, she was conscious, oriented, responding to commands. She had a tracheostomy in situ, no pallor, icterus, cyanosis, clubbing, pedal edema. She had bilateral, multiple enlarged, firm to heart, matted, non-tender cervical lymph nodes, and no other axillary or inguinal lymphadenopathy. On oral examination wise, it's normal, no lesion seen. CVS, RS, and abdomen and CNS examination were normal. On investigations part, hemoglobin is 12.1 with MCV of 86, WBC of 6,200, neutrophil of 52, lymphocytes of 35, monocytes of 11, and eosinophils of 2, and creatinine was 0.64. And liver function test actually had total bilirubin, transaminases, and alphos was normal, but total protein was elevated. It is 9.7 with albumin of 3.9, and TSH was 1.779. And her ESR was 10, CRP was 13.7. Her serum electrophoresis showed a band in gamma region. And immunofixation electrophoresis was normal. Her C3 and C4 were normal, ANE normal, and other parameters were normal. So we did an ultrasound neck. It showed bilateral enlarged cervical lymph nodes.
What is the clinical diagnosis?
Sir?
Before you start all these cases, what is the clinical diagnosis?
She came with a symptom complex of bilateral, non-tender palpable neck swelling, sir.
So what are the differentials? Sir is asking what are the differentials? So you have presented a history examination, you summarize it and you give a list of differentials and then go ahead for the diagnostic test.
So differentials initially we considered were sarcoidosis, amyloidosis, or IgG4 disease, or Castleman disease, Kikuchi disease, or any liposomal or lipid storage infiltrative disorders, or it could be we thought of any histiocytosis or benign neoplasms. We thought like that. So we did an ultrasound neck which showed bilateral enlarged cervical lymph nodes, largest on level left level 2, which measures 34.5 millimeter. It's a diffusely bulky thyroid gland. Bilateral parotid and mandibular lymph nodes are normal. Followed by which a CT neck, thorax, and abdomen was done, which showed multiple large enhancing nodes in all the levels of bilateral neck, including bilateral parapharyngeal, posterior pharyngeal, and supraclavicular nodes. And here airway compromised due to multiple nodes from the oropharynx to the level of epiglottis, rest nil significant. So this is the CT taken, and she had enlarged lymph nodes. She had multiple enlarged lymph nodes over her bilateral neck. So, can anyone guess the diagnosis? So, actually, the diagnosis is IgG4 related disease. So, this should have come before, sorry. And the differential initially we consider as sarcoidosis, amyloidosis, histiocytosis, IgG4 disease, Castleman disease, Kikuchi disease, infiltrative disorders like lipid storage diseases, and malignancy or infective unlikely or some benign neoplasms. So followed by which serum IgG4 was done, it is 7.03 and kappa lambda ratio is 2.11. We did an excision biopsy of the right cervical lymph node, showed some no storiform fibrosis or obliterative phlebitis, but in foci, IgG4 positive plasma cells amount up to 170 per high power field, and IgG stains many plasma cells, approximately 320 per high power field. The ratio of IgG4 is to IgG is 53, which is greater than 50%. And ENT was consulted, followed by which the biopsy from nasopharynx was done, soft tissue biopsy, which is consistent with IgG4 disease. So first, what is IgG4 disease? It is an immune-mediated fibroinflammatory multi-organ systemic condition. It is a rare entity. Its incidence is 0.28 to 1.08 per 1 lakh population. And it is more common among men, middle-aged and older men are mostly affected. And it is usually characterized by a dense lymphoplasmacytic infiltration, which is rich in IgG4 positive plasma cells, storiform fibrosis, and not often, but not always elevated serum IgG4 concentrations. So, potential role of exposure to occupational antigen has been suggested by cohort studies that observed a higher prevalence of disease among blue-collar workers, that is building contractors and plumbers. A Dutch study of 25 patients with IgG4 sclerosing cholangitis and or autoimmune pancreatitis, it showed 88% had history of blue-collar work of at least 1 year. And similarly, Oxford cohort, 44 patients with established IgG4 disease, 61% has blue-collar professions, and they recalled chronic exposure to potential harmful compounds. So these are some of the previous nomenclatures used for IgG4-related disease: Mikulicz disease, familial multifocal fibrosclerosis, Kuttner's tumor, IgG4-related sclerosing disease, and so on and so on. So what is IgG4 molecule? It is actually a unique antibody. It is the least abundant IgG subclass. It accounts for less than 5% of the total IgG in healthy persons. IgG4 production, like IgE production, is controlled primarily by T helper 2 cells. T helper 2 cytokines such as interleukin 4, interleukin 13, they enhance the production of both IgG4 and IgG. But in contrast, interleukin 10, 12, and 21, they shift the balance between IgG4 and IgE, and thereby favoring in IgG4. So pathogenesis, there are some potential triggers like autoimmunity and infectious agents, which stimulate the T helper cell 2 immune reaction. So they predominate and they secrete interleukins like 4, 5, 10, 13, and transforming growth factor beta, followed by which the serum IgG4 get elevated and IgE concentrations and progression of fibrosis. They get infiltrated into cells and causing organ damage. So this is some potential triggers. It is triggering the T helper 2 cells, followed by which interleukins are secreted, and followed by which IgE production, IgG4 production are produced, and they get infiltrated into a cell and causing organ damage. So presentation is usually, it is a varied clinical presentation. It usually presents subacutely, and most are not constitutively ill. So it can affect every organ, including salivary glands, biliary tree, periorbital tissues, kidneys, lung, lymph nodes, meninges, aorta, breast, prostate, thyroid, pericardium, and even skin. So lymphadenopathy, it is usually observed together, but it can be isolated and only manifestation also. They seldom undergo storiform fibrosis. And most common presentation is autoimmune pancreatitis type 1. It is also called as lymphoplasmacytic sclerosing pancreatitis. It is the prototype of IgG4 disease, and it accounts for 2% of patients with chronic pancreatitis. It can either present as a pancreatic mass or as painless obstructive jaundice. And other presentation were IgG4 relating sclerosing cholangitis and salivary and lacrimal gland involvement. It is called Mikulicz disease, and submandibular involvement, it is called a cutaneous tumor. Retroperitoneal fibrosis is seen in 3 to 19% of patients. Aortitis and periaortitis, usually thoracic aorta is involved more than abdominal. And thyroid disease, renal thyroiditis, and lung and pleural disease, pulmonary manifestation, it mimics sarcoidosis. In kidney disease, the most common manifestation is tubulointerstitial nephritis. Can even affect the skin, IgG4 hepatopathy, lymphoplasmacytic gastritis, and even CNS involvement with hypopituitarism associated with IgG4 related hypophysitis and pachymeningitis. So these are previously recognized conditions now acknowledged to fall within the spectrum of IgG4 related disease. And for diagnosis, histopathological diagnosis of biopsy specimens remains a cornerstone in the diagnosis of IgG4 related disease. Elevated concentrations of IgG4 in tissue and serum are helpful in diagnosing the IgG4 related disease, but neither one is a specific diagnostic marker. Interestingly, serum IgG4 is normal in up to 30 to 40% of patients with biopsy proven IgG4 related disease. In a recent large study, serum IgG4 was found to be elevated in 82% of patients with IgG4 related disease, but only 22% of those with an elevated IgG4 met IgG4 related diagnostic criteria. And correlation with specific histopathological findings is essential, regardless of the serum IgG4 concentration, the number of IgG4 positive plasma cells in tissue, or the ratio of IgG4 to IgG in tissue. So the key morphological features are there will be dense lymphoplasmacytic infiltrate that is organized in a storiform pattern, obliterative phlebitis, and also will have a mild to moderate eosinophilic infiltrate. The inflammatory infiltrate is composed of an admixture of T and B lymphocytes, which are B lymphocytes are predominant. And all immunoglobulin subclasses can be seen in the involved tissue, but IgG4 predominates. And the ratio of IgG4 bearing plasma cells to IgG bearing plasma cells, they further assist in confirming the diagnosis. A ratio higher than 50% is very suggestive of diagnosis. In our case, it is 53%. And also a diffuse plasma cell infiltrate with more than 30 IgG4 positive cells per high power field, and the ratio, as I mentioned, greater than higher than 50% is more evident, so that the disease can be IgG4 disease. So in our case, we had per high power field 320 cells per high power field. So the treatment is glucocorticoids are typically the first line therapy. Usually it is started at a dose of 0.6 mg per kg per day for 2 to 4 weeks, followed by which it was tapered over a period of 3 to 6 months up to 5 mg per day, and then continue at a dose between 2.5 to 5 mg for up to 3 years. So if it is a recurrent or refractory disease, B cell depletion with rituximab, it appears to be a useful diagnosis. So if a patient relapses after stopping steroid therapy, we can again try repeat therapy with steroids, and also we can try some second line immunosuppressive agents like methotrexate, mycophenolate mofetil, or azathioprine. So in patients treated with rituximab, IgG4 concentrations decline sharply, although concentrations of other IgG4 subclasses remain stable. This decline is associated with clinical improvement within weeks. The important thing is untreated IgG4 related disease often progresses from inflammation to extensive fibrosis. So patients in whom fibrosis has become well established are less likely to have a response to glucocorticoids and rituximab. So the take home points is IgG4 related disease, it is a multi-system disorder. Serum IgG4 is not a diagnostic for IgG4 related disease, and steroids are often the first line therapy, but rituximab may be used as a steroid sparing agent. Thank you.
Thank you, Akash. So what was your patient's occupation? Was there any exposure to?
No, sir, no.
No exposure
No
at all.
exposure.
You started your patient on steroids.
Yes, sir. We have started the patients on steroids and asked her to review after 1 month.
Any question?
So far, what is the course for the patient?
Course. Actually,
Following your treatment, has the patient responded at all?
sorry, sir.
Has the patient responded?
I have actually we have just started her with steroids, sir. 0.6 mg per kg, and I have asked her to review after 1 month. So it is between only 1 week has been over so far.
Has she improved?
She'll be coming back now.
This lady's symptoms have been there for 16 years.
Yes, sir.
So, what do you hope to achieve by giving her steroids now?
It is compromising. The only thing worrying is it is compromising her airway, sir. So,
Are there randomized control trials saying that steroids will change the natural history, that airway compromise will reverse, will be
the size of
later?
yes, sir. Actually, the size of lymph nodes and is slowly.
But it showed massive nodes. No?
Yes, sir.
Huge nodes. Going on for 16 years. I think steroids will get better now. Did you look up the other studies, randomized control trials?
Yes, sir. Usually lymph nodes, they haven't mentioned specifically for lymph nodes, but for other organs like pancreas and all, there is a
Answer that question. Sir, asking a specific question.
lymph nodes. No, sir, I haven't seen.
And why did she come now? The problem that she noticed the lymph nodes
Because
16 years ago. Why
yes,
did it
sir.
come now?
Recently, for the past 1 or 2 months, it started compromising her airway more.
Tracheostomy done?
Sir,
When was the tracheostomy done?
tracheostomy done on February 2023, sir. 2 months before, followed by which biopsy was done. So, followed by which she came here.
There's no surgical role. Debulking.
No, sir.
What sir is saying is, you also mentioned saying once it goes into the fibrotic stage, there is no role for steroids. So she's been going on for 16 years. So sir is asking, will
For
there
her,
be any
actually,
role
the
of steroids?
biopsy it showed no storiform fibrosis so far, sir.
What did it show?
It does not
Biopsy.
show any fibrosis so far.
What did the biopsy show, other than no fibrosis?
I have mentioned IgG4 stained plasma cells, ma'am, and IgG4 is to IgG ratio they have mentioned. It is greater than 50%, that is 53%, and 320 IgG plasma cells per high power.
It's interesting more after inflammatory stage, not gone into fibrotic.
Yes, sir, yeah.
If you give steroids, that should improve.
Yes, sir.
So it's quite a slow growing process over many years. Only thing fortunate is that it's not gone into a
Fibrosis.
And lymph nodes are apart from the neck, where it's
No, sir, only in the neck. No axillary, no inguinal lymph
all
node.
other, there's no other.
No other lymph nodes.
Okay, thank you. We'll move to the next case.